Thank you very much. I'm really grateful and I'm honored to be here to present my project funded by SPF. The past 12 years, I had probably several projects funded by SPF, and I'm really grateful. Now we heard we are now in tipping point for the treatment of SPF and also PLS. So I think this is a great time, and the SPF has now new administration leadership. So we are really looking forward to greater progress in this field. So I'd like to talk to PLS natural history study update. So today's topics, I'd like to speak briefly history of and characteristic of PLS, and also progress we have made in the past several years, and the PLS natural history studies, current studies, and also we are facing difficult issues and potential solutions. So what about the PLS? PLS is such a rare disease, and initially described 107 years ago by Jean Martin Charcot, who is the father of neurology, first professor of neurology in Paris. And it is described as hysterical attacks. 1981, Bill Richardson, Harvard, described the PLS with full autopsy studies. And then 1980s until 2010, there are various centers described PLS in their clinical experience. And 1992, Pringle and Hudson published a seminal study of PLS. So then several authors described how we can make diagnosis of PLS up to 2006. And then 2002, Spastic Paraplegia Foundation was established in PLS, covering SPF, HSP, and PLS. So what do we know about the PLS? And incidence is quite rare. And I'm specializing in ALS, and I see 100 ALS patients, probably one or two turns out to be PLS. So it's a very rare, and probably we have 75 to 125 new cases, just simply estimated. So at the given point, probably 2,000 patients in the United States. So cause and pathogenesis unknown. Nosology, that means diseased entity is unsettled. Natural history is obviously not determined. Clinical features variable, and the clinical description dominates literatures at this point. And diagnosis is still uncertain, particularly in early stages. And assessment, upper motor neuron scale, and the PLS-FRS were developed, yet to be determined and tested in real world. Neuroimaging is probably most progressed in relation to ALS and PLS studies, and the neurophysiology is important to make how to make a diagnosis. Biomarkers, if anything, just iffy, and the genetics just the beginning, and the clinical trials never done. So PLS is such a entity we can call very rare, puzzling, and obscured disease. PLS is considered as an extreme end of ALS spectrum. ALS here and the PLS here, the probably broader spectrum. And we conducted prospective 5 multi-center PLS Cosmos studies several years ago, again, funded by SPF and also part of NIH funding. And the PLS-FRS has been developed for the PLS natural history studies for the future clinical trials. International PLS conference was held in 2019. The reason was I presented to proposed to clinical trial readiness, which we heard this morning, and essentially we are told you are not there yet. So that's the reason we need to learn more PLS, and so that's the reason we developed the PLS diagnostic criteria after this meeting, and the PLS conference supplement has been published. I can tell you a little bit more detail later on. So PLS is a disease of upper motor neuron. Already we heard just about how upper motor neuron controls lower motor neuron, and ALS and PLS, ALS affect upper motor neuron, lower motor neuron, but PLS is just solely affect upper motor neuron and the tracts. So upper motor neuron, lower motor neuron involved, that turns out to be PLS, and the pure lower motor neuron, sometimes called progressive muscular atrophy, and the predominant upper motor neuron or pure upper motor neuron is PLS. So PLS is how we define, still unclear. There's clearly some overlap, small overlap with sporadic ALS and the familiar ALS, and also HSP. Some HSP turns out to be PLS, and also neurodegenerative diseases, particularly Parkinson's disease, express sometimes PLS-like. So we studied this PLS Cosmos study several years ago and published, and we found several familial and C9 ORF mutations. So some clearly familial ALS genes phenotypically expressed as PLS, about 10 to 15%, but still rest of 85+ percentage, we don't know any genetic mutation at this point. So I'm just presenting ALS-FRS-R revised. This is, if you talk to any doctor who deals with ALS, this is most widely used, highly validated scale called ALS Functional Rating Scale, and everyone knows. So I want you to pay attention with red figures. We studied the PLS 1 year, 2 years follow-up, and compared to ALS. When you use ALS-FRS, the movement of changes actually is so small. As you can see, only 0.05 compared to ALS moves 1.38 declining, minus sign declining. So if you use ALS-FRS, the changes are so little. So we thought maybe we need better, more sensitive scale. That's the reason we developed multi-center PLS-FRS scale. So 21 centers, well-established, highly known centers involved, 21 centers participated in 6 months studies and looking at the scale, and we produced the PLS-FRS, PLS Functional Rating Scale, adding 2 additional points to up to pulmonary function. So total scale is 68 instead of 48 for ALS-FRS. So we think this is clearly improved sensitivities. We see, as long as we see even 3 months to 6 months clear changes with PLS-FRS. So this paper was published. And then another thing is we need to learn more about PLS. So international experts interested in PLS gathered in Philadelphia. About 75 people gathered. Multiple funding agencies supported these studies, including NIH, of course, SPF, and so forth. So we did a very fruitful 2.5 days meeting, and out of this meeting, we published the primary lateral sclerosis consensus diagnostic criteria, and this is now most people using this for PLS. And if you look at PLS is such a small proportion for this motor neuron disease, including ALS. ALS dominate studies. So supplement, including clinical spectrum, and neurophysiological findings, neuroimaging, and also genetics of primary lateral sclerosis, and understanding of neurobiology, and including, of course, Dr. Ozlina, and neuropathology, measuring how we measure a progression of PLS, including PLS-FRS, and also clinical care and therapeutic trials, all those are published in a supplement. So So after those preliminary studies, naturally we need natural history studies. So current status of PLS is now, used to be, PLS has been a rare, enigmatic, neglected motor neuron disease, not anymore. And international investigators and disease organizations have recently started paying serious attention to PLS. The reason is multiple funding agencies, including NIH, ALS Association, MND Association, those centers are funding PLS. So that's the fact. And also HSP PLS Canada has been just recently established, and NEWS has long-standing upper motor neuron committees and developing, supporting these studies, and also we should have every 2 years a PLS conference organized by Paganoni, but is interrupted by COVID problem. So when I presented clinical trial readiness grant, there was no medication, there is no biomarkers, etc. However, now we have clearly possible medication is progressed. So just we heard by Dr. Oslinger. So we are going to hopefully use those studies. Now, why do we need a PLS natural history studies? Obviously, this is the logical progressions. And establishing natural history is a prerequisite for designing future clinical trials. Without knowing natural history, it's just you can't do clinical trials. And also we have to know what's the best outcome, best measures to detect the changes in the PLS. And we should be able to validate the variability of a new diagnostic criteria. We made a diagnostic criteria. We believe this is a good criteria, but not tested in natural surroundings. So this will be the opportunity to test the validity and develop biomarkers for the future and improve understanding of PLS. Those are purpose of natural history studies. So again, this natural history study is funded by SPF, ALS Association, and Mitsubishi Tanabe, MDA Wings, and also private donation by Mr. David Marin and the family. So these now, we have 30 centers, US and Canadian site, again, very prominent centers included, and so those pictures showing a happy face in United States and Canada, working with this natural history studies. So structures are certainly funding agency critical to give us money. So we have Columbia is coordinating centers. Grace Jung is a study coordinator doing almost everything with me. And we have steering committee, we have EMG, other committees, and the 30 sites feed the data to Neurobank at Harvard, and Alex Sherman is actually pro bono helping these studies, and the biostatistician is Ken Chung at Columbia. So we have all those structures placed. And then I have to tell you, inclusion criteria is a little bit a busy slide. Age has to be above 25 or older. The reason is we have to be adult, and also younger age has some hereditary upper motor neuron disease potentially included, so we try to exclude those. Inclusion criteria already we heard several times, try to make disease pure as pure as possible. So diagnosis based on new PLS diagnostic criteria, and symptom onset has to be less than 15 years. And of course, patient has to be independently walk with or without assistive device, because walking speed is one of outcome criteria. And cases with the molecular testing has, if done, HSP and other related mutation excluded, and expected to have at least some bulbar symptoms, because the PLS affect not just lower leg, upper arm, arms, and also bulbar signs such as difficulty of speech, some swallowing problem, drooling, etc. So at least the symptom should be present. Yet, if there is none, if upper extremities, upper limbs involved, we are not excluded because we need patient to study. Upper motor neuron symptoms and signs in region other than legs obviously is important, and normal neuroimaging, because sometimes abnormal neuroimaging is causing of upper motor neuron signs. Neuroimaging is very important. And also no active neurological diseases, and no active medical disease for some time, and residing commutable distance, and someone in family history, immediate family history has ALS and PLS cannot be included, and the disease duration less than 5 years. I'm sorry, this one is somehow turns out this old slide, but 4 years, and if EMG was not done in this period, EMG should be done, yet also we expanded criteria, ease up a little bit. And the participant understanding purpose of the study is important. Capacity assessment is done, and also able to sign informed consent. Exclusion criteria is relatively small. Unwilling to unable to give informed consent obviously cannot join the study. Upper motor neuron symptoms and signs only in the legs, that's not PLS, and also unwilling to or unable to visit the study site, that's another requirement. And cognitive impairment, obviously clinically obvious cognitive impairment cannot enroll, and someone participating in clinical trials cannot participate in this natural history studies. So we have 50 definite PLS cases. 50 early means actually anyone who started disease even less than 24 months, and 24 months to 48 months is said to be probable PLS on new clinical criteria. So we include everyone. Just as anyone started disease, we include if there is a less than 48 months. But 50 definite cases 4 years after, but less than 15 years. So two groups. And the reason why we separately including early cases, I believe any neurodegenerative disease, sooner, earlier treatment, initiation of treatment is far better than later treatment. So that's the reason, if anything, any window which makes more effective with the medication, we have to deal with early cases. So studies develop baseline, 6 months, 12 months, all those are on-site, in-person visit, but the 3 months and 6 months is just a telephone, and the baseline obviously busy with all those inclusions, and we use many different outcome measures, and 24 months is only telephone, so continues to 24 months, but key is 063 and 39 based on in-person and telephone visit. Telephone visit are also done by 0612 in-person in addition to we do telephone investigation. The study schedules in different ways. For example, cognitive testing is done by via phone. We have good experience with over the phone cognitive testing, and also we do durable medical equipment testing and medication review on phone, and PLS-FRS, the primary outcome is via phone. Pataka is bulbar speed, finger tapping, foot tapping, and also ALSQ is actually quality of life measurement, and also Rose test is a disability for ALS, and the timed up is sitting position to up, and turn around 3 meter is walking distance, walking speed we check, and furthermore urine blood test and EMG test done at the 12 months on site. So those are done, and the 24 months just via phone telephones. So outcome exam by our evaluator is cognitive testing. There are several different cognitive testing done, and PLS-FRS. Already I mentioned those, and specifically this ROSE means Roche built overall ALS disabilities developed by Dr. Fournier. Emory is new, and we are testing again with these clinical trials. And the speed of alternative movement, such as pataka, 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 or finger tapping or foot tapping, is representing quite well for spasticity or upper motor neuron impairment. So that's we're including, and those are done by over the phone. So we have standing committees. Steering committees actually steer the entire project. I'm PI, but again, steering committee steers the entire project, and any unforeseen problem issues, we have to ask the steering committee, approve data and biosample sharing. And one of the reasons we start this natural history studies, share the data. And all data is open to share with any pharmaceutical companies, because anyone who wants to develop new clinical medications, those natural history studies are critically important. Now, prove data and biosampling sharing, and interpret result and guide publication. This is a steering committee. We have also EMG, diagnostic validation, and publication committee. Just I'm going to tell you a little bit briefly. Those are members. And particularly EMG is very important because they look at EMG findings and tell us whether we can include or not include based on EMG changes. And our chair is Dara Heitzman, Eric Sorensen. Every time very quickly evaluate EMG and tell us their opinion. Based on their opinion, we go ahead enrolling or not enrolling. So EMG also decides what muscles tested at the end of 12 months, and also we can compare initial EMG and the 12 months point. This is very interesting study, how PLS changes EMG. There is no change, that means no upper motor neuron, or certain EMG changes occur within 12 months. So that's what I pointed out, and how we can already muscles are selected, and we decide what the study done at the 12 months point. So diagnostic validation committees is these members, and we determine specifically PLS diagnostic criteria, and how we do it, and two members are selected and evaluate clinically and facing the PLS clinical diagnosis. So whether validation is done or not, and also Ken Chan biostatistically analyze how often, how validly we can certify this clinical criteria, diagnostic criteria. The publication committee is all those members, and they look at all draft publications, comments before publications, and also they solicit any interesting paper, a project, and so forth. And the primary paper is natural history studies, and already how we describe how members listed and so forth, already determined. Otherwise, sometimes later on some disagreements or so forth can happen. So we decide at the beginning. and other publications also plan to do with this studies. So data management means all data goes to Neurobank at Mass General, and Eric Sherman kindly gave us the opportunity to pro bono. So they do everything free service. And again, it's very helpful because this data can be disseminated through Northeast ALS study group. Biostatistical analysis done by Ken Chan. He has a lot of experience with previous ALS studies, and he is going to look at, characterize the natural history of two patient cohort and about early and well-established cases, and provide information for the randomized clinical trials. And also analyze which outcome is more reasonable, and particularly outcome of PLS-FRS, and other outcome including Pataka and finger tapping, foot tapping, rows, and neuro QRS changes over 1 year, and how they change from baseline, and analysis using generalized linear mixed effect model. He's using those analysis and give us important result for the future studies. We had at least 3 Zoom conference to initiation and training May 2021, and ever since beginning of the studies, we have a monthly conference call and look at how they're doing in terms of planning enrollment and so forth. And besides that, we have very frequent email exchange. Now, so investigational research within this PLS natural history studies, obviously natural history will be determined, and the validation for the current PLS diagnostic criteria is very important. Again, as I said, very interesting to see how EMG changes occurs because everyone has the same muscle examined. And the DNA molecular analysis to identify novel genes, if any, there, and Matt Harms will be in charge of this genetic studies, and also validate increased oxidative stress in the urine, and also novel biomarkers. Lipidomics is now working on. I'm going to tell you briefly all those changes. And already we established a biorepository for the future studies. So Matt Harms is at least look at the C9 determination by repeat prime PCR, and also looking at specific familial ALS genes, HSP genes, and PD genes, because we know about the 10 to 15% may, the disease called PLS may have those contamination or mixed up with those other disease. So we are going to exclude those genes, and also eventually genome sequence will be done. And we are not going to report to the patient, we report to the investigator. The investigator has to study new, determined, clinically useful genetic data, and this is purely investigational. So I'll tell you about the biomarkers. We did early PLS studies. We found increased urinary isoprostine and also 8-oxo-D-guanosine oxidative stress in the urine, and compared to healthy controls based on, we call this group called arrest controls. So clearly isoprostine is different, but this needs to be confirmed, and I have not published this data yet until we confirmed. So metabolic alteration in ALS and PLS. We know something different in fatty acid and also triglyceride in disease CSF changes. As you know, if you look at the brain and the spinal cord and the dry weight, 50% dry weight of brain is lipid. So brain is made of a protein and lipid, half and half, and it's very, very important how lipid contributing nervous system. So we clearly interested in triglyceride and lipid changes, and so we did earlier studies, and Stella analyzed lipidomics. We have at least 230 species of lipid in the blood, and we looked at the ALS and PLS is baseline and 24 months later, and clearly changes with triacylglycerol and the sphingolipids and phospholipids changes, and appears to be more changes becoming prominent at the 24 months. So we know there is a difference in lipidomics in ALS and PLS, and recently Dr. Ik-Jae Lee, who is a younger member of our ALS team, and he did very sophisticated machine learning. Machine learning means chopped off all those segments of lipid and randomly machine analyzed, and they pick up what's the significant changes, and then go back to the material specimen to reanalyze. What they found is most discriminatory variables they found is Mg monoacylglycerol, chain number is 18, 18.2, 18.3 is very significantly different between PLS ALS and also PLS controls. So this is most exciting change in lipidomic changes, and is writing papers to publish at this moment. So this is another very exciting lipidomic studies, and certainly we have to study future. Now I have to show you the realities. The studies begin in 2021, and subcontract agreement takes a long time, even 1 year after, still not 30 centers are completed. And also enrollment number is slow. It started about October 2021, and then last month now not zero, but this month now picked up more. So total number is now at the end of June 19. We are looking for 100 cases. So very slow. What do you say? Just too slow. So extremely frustrating. So I have to show you. When PLS natural history study is successfully completed before issues, we will have a largest multi-site study to establish PLS natural history. That's very true if it's finished. And large collaborative studies funded by multiple funding sources, SPF, ALS Association already, Mitsubishi Tanabe, private donation, and Neurobank, and so forth. So this is a multiply funded, yet still a shoestring budget. And then the effective use of a smartphone to obtain outcome data, giving a less burden to participate patients, that they don't have to come to center. That is useful, and also same person asks question, so outcome data is more uniform. And the PLS natural history studies will be succeeding appropriate clinical trials in PLS. This is one of the most exciting. Just we heard excellent presentation by Dr. Ozinunda, and so we have now potential medications, and providing a series of novel research data, understanding of disease mechanism, and also new biomarkers for PLS, and validating current PLS diagnostic criteria, so and so forth, such as EMG changes, etc., etc. So I think this is a very exciting studies. Yet we have a problem, difficulties, and potential solutions, if any. So PLS is simply so rare, And maybe that's the reason. And now SPF blasted the email to all members if any potential participation, interest, and so forth. We are calling, emailing to surrounding doctors to look for those cases. We continue to publicize the study. That's the effort we are making. Multi-site study poses an administrative nightmare. And the studies, one site, each IRB, and also subcontract is so slow. And the slowness is probably worsened by COVID. So that's the actually true nightmare. Enrollment criteria are too strict. Yes, we have to agree. We made a little bit more uniform PLS cases. Therefore, not this, not that, not this. We made such effort. Yet it turns out to be make enrollment difficult. So a little bit we eased up EMG criteria, and also disease duration eased up a little bit. So we hope we have more cases. But again, we cannot expand too much. Then we have a lot of different cases potentially in the group. COVID-19 has so greatly interfered our entire studies, and now we hope COVID is gone. No one is wearing a mask, so at least COVID is on the way of going, but still effect is there. So that's another problem. And also PLS natural history is likely to compete against ALS clinical trials. ALS clinical trials are often done by pharmaceutical companies, and they fund centers well because they have to finish studies on time. They need a number of patients. They are not totally stingy, not like PLS natural history studies, because our studies, I have to be honest, shoestring despite of multiple funding sources. So it is very difficult to compete, because if time is limited, they have to spend the time. They tend to spend more time for ALS. And that is just a given. It's very difficult to compete. And in the same centers. Donation made by Mr. Marin to reward. If you enroll more patients, we give some extra reward. But some centers are totally not acceptable to reward the system. Therefore, we have to change how we can support those sites. And also, budget allocate for patient study is still largely preserved. So we have only 20 cases enrolled, so 80 patient budget is still there. Yet, when we start studies, coordinator salary has to be spent. And the coordinator's salary is essentially gone. So what do you do? Without the coordinator, we cannot study, I cannot be doing everything. Therefore, certainly we need more support to continue. My feeling is, yes, in ways this is not a very successful studies and facing a lot of difficulties, but we are doing smoothly, slowly, but smoothly. So we have to support this study until certain numbers to attain. That's my belief, and I hope SPF leadership listen and support our study continuously. So thank you very much for continuous support and generosity for the foundations, and we are looking forward to move expeditiously in the right directions. So if you have any question, I'm happy to answer any of you if I can answer. Thank you so much.
Anybody question? Here you go. I'll bring you the microphone.
Thank you very much. It was a very good talk, and I want to say I appreciate what you're doing. I'm a patient with PLS, so it's very frustrating to, and full disclosure, I work in pharma also, and I've been in pharma for 30 years, working in a lot of rare diseases. So I've got very good, background on clinical trials, enrollment, studies, everything that goes involved with that. Now, I spent my whole career on that side, and now I'm a patient. I'm dying to get into any type of clinical trial, but there's just not much out there. Everything is around ALS, a lot of the clinical trials, and we're excluded from those.
Exactly.
So I do admire your work. One of the questions I have is when I look at those numbers and they're so low on the enrollment, just trying to get people in for a natural history study, how will you even get that into clinical trials? I've worked in some other rare diseases like Duchenne muscular dystrophy, cystic fibrosis, and it was just hard to get, and you could probably appreciate this because some of the companies I worked for were in Cambridge, just getting the number to treat. You talked about a study, Dr. Fakari, I think you said in N of 17. So in PLS, how do you work with the FDA to maybe have them change some parameters so you don't have to have as many people in a study, number one, because it's so rare. Does that make sense?
Yes.
And then what do you do with such low numbers with such a rare disease? Thank you.
I think we need to develop something again out of box thinking. This is very traditional, and 50 early cases, 50 definite cases, and traditional statistical analysis. We have to develop very few cases. Maybe we heard N of 1. One case. Well, one case might be different from most typical ALS, but if you do deal with one case, extreme situation, repeated medication, randomized, medication, placebo, placebo, medication, medication, placebo in one patient, do placebo-controlled study to one patient. If we have 20 patients like that, that's possible. But again, duration may not be too short because disease such as PLS moves so slow. As I shown, you cannot use ALS-FRS. We have to use much more sensitive measures. We don't know what measure is better. PLS may not be best. Maybe something other measures. We need biomarker. Biomarkers, I don't think FDA ever approve a medication based on biomarker except something biomarker clinical so geared closely. So I think biomarker is another crucial moment. If biomarker improves in shorter period, then we may not need a large number. Yes, SPF is a key foundation to disseminate information to all constituency for clinical trials, and publicizing effort is critically important. I hope I answered your questions.
You did, and thank you very much. And then just the last question, if I can piggyback on this, I think Dr. Fakari talked about the collaboration among medical centers, tertiary centers, the international community to kind of share information and research. I'd like to know if you're doing anything with other physicians, researchers, geneticists outside of the United States to try to speed up the research. So again, appreciate your time. Thank you.
I heard this morning we have to work this kind of super rare disease, extraordinary rare disease. We just cannot work with us. United States is not good enough. And I tried to get the funding and the patient population with MND Association, Great Britain. They are interested in supporting PLS, and somehow working with Martin Turner's, London and so forth, and they are willing to support, yet again, because of COVID, everything just went disarray. So I have to admit the difficulty, but indeed we have to work with international, global sense to deal with this rare disease.
Dr. Mitsumoto, right here.
Yes.
Thank you very much for the presentation and your work. I had a couple questions. Did I understand correctly that HSP can progress to PLS, or is there...
Can you speak a little bit closer?
Yeah. Did I understand you correctly in that HSP can progress into PLS, or is there just overlap?
There are very small proportion of HSP clinically present PLS, but almost all HSP is a different disease. And this foundation supports the two diseases, and how they are close, how they are intermingled, both diseases, still a little bit uncertainties. But my understanding, you can ask expert, but I think it's quite different diseases.
Okay.
Yet, upper motor neurons are affected, and more distally means tip of longest nerve may be affected first, then gradually going up to the neuron. And PLS might be disease start with cell bodies. Cell bodies, the nerve fibers, in fact, just one part of the body, one part of cells. So where the changes, for example, in human bodies, foot disease going up to the leg, or brain disease affecting the foot eventually, those mechanisms so are different. But again, we have to understand those mechanisms fully. And studies already being done and presented this morning. It's just fascinating.
It is one more question. Is the any research in ALS? Do you see benefit to PLS or HSP?
Yes, I think is all those are neurodegenerative disease, and I'm specializing in ALS. The reason why I became interested in PLS is only small portion. I told you one or two, or maybe perhaps three at the most, terms of the PLS among most of ALS. And PLS, people with PLS progress very, very slow pace. So patient with the PLS may be protected against the lower motor neuron disease, such as spinal cord brainstem. And if we know the mechanism, we help each other. And so vice versa, mechanism, those neurodegenerative disease study for ALS is must help for PLS and HSP. And also, I think disease is not completely separate. I think it's, if you look at the disease, neurodegenerative disease, like a cloud. Some patient has a little bit more cognitive impairment, somewhere a little bit more different impairment, bladder and urinary problem and so forth, and somehow different Parkinsonian features, Alzheimer's features, ALS features. Somehow something happens, although core is always a pure standard cases. So I think you learn more disease in PLS, HSP, and ALS. We help each other greatly.
Dr. Mitsumoto,
Yes.
here's another one.
Hello, doctor, and thank you for the information you've been giving us in this presentation. One slide I thought made mention of lipid processing in the brain. And I'm wondering, recently there's been talk of a gene called TMEM63C. I'm wondering if that affects the studies that you're doing.
You got me. I do not know. I did not mention. What's the is that the name of gene?
The gene, I believe, is TMEM63C.
I am sorry, I cannot answer. Maybe someone else? Dr. Fink? He's a god.
Can you tell me more about that gene? I'm not familiar with that designation.
Oh, it's on the SPF site. It's funny that it's only been on there for the last couple of weeks.
Do you know?
Oh.
Here, come over here.
I think it's a great question. I don't know much about this particular gene, but I think it's been published as a new HSP-associated gene. And it is a protein in lipid metabolism, as far as I know, like many others are involved in lipid metabolism. I think that's the connection.
Well, time to leave.
Wait,
Well-
just a moment. Dr. Fink, did you have a follow-up? Okay. There was another question over here. Last question. And then Tim's got some things to add to you guys, so don't get up and leave yet.
This will be real quick. Do you have, if I know people that have PLS and they might be interested in participating in your study, who do I contact? Who do I have them contact? They don't respond to emails.
Can you speak a little bit closer?
Contact information for PLS patients that might be interested in participating in your study.
Okay.
Who should I have them call?
She is asking, who does she need to send PLS patients to in order to participate in your study?
Right. Okay. So how? That's a question, right? So the location, where do you live? You can call me. Actually, you can email me. I mean, email is the best. To email me, I'm happy to answer any question if possible. Which sites are closest to you, and I'm happy to identify. Actually, another thing is such a rare disease, if center-based studies, we have 31 centers, very well recognized, good centers in the United States, but United States is such a huge, vast countries, and still there are location, Midwest and so forth. There is no centers, and but if there are patient, potential candidate and eligible for the studies, and how we can do those patients, and I think my thinking is, I think this foundation, SP Foundation, should help directly to the patient, communicate to the centers, somehow more easy administrative system agreement to the center close to you, enroll one patient, and we study over the smartphone and so forth. So we can train basic things if there is a physical therapist, so we can do more effectively rather than comes to several hundred miles to drive to some famous centers. That's just so cumbersome and difficult and discouraging for the patient to enroll. So we have to devise something more effective way to enroll this rare disease.
Can I take one more question? Mr. Gora. I'm sure this was a follow-up from the other two, right? There you go. Here's a follow-up.
Oh, okay. I'm participating in the study, and I have the email I'll give you, but it's Grace Yang. She is.
Hey, I tell you what, let me offer this as a suggestion. He's going to send it to me, and then we're going to have it available on the website, or we will have it available individually, whoever may request that email. Okay? We'll get that information to everybody. Okay, Greg, you want to wrap us up? Thank you so much, Dr.
Thank you very
Mitsumoto. We
much.
appreciate your
it.
help.
Thank you.
My goodness, what some great information.